So I'm super excited to talk to you all about this. I wish I was in Hawaii giving this. That'd be so nice. But here in Utah, where it's kind of chilly, it snowed yesterday. Um, but yeah, these are the disclosures, no major disclosures. And then my background, like Melissa mentioned, I'm a doctor of physical therapy, and I've treated hundreds of patients with ME/CFS and long COVID from a variety of backgrounds and circumstances. I've treated patients who are homeless with ME/CFS and others who have plenty of financial resources, some patients who have no one to help them, no family, and then others who have plenty of caregivers and family support. So, a variety of circumstances, health conditions, and comorbidities. And really, this exploded after the pandemic, where my my percentage of patients with ME/CFS really expanded with long COVID. And I continue to treat full time and then create educational content. So those were my objectives. I wanted to touch on this. Utah recently passed legislation to include physical therapists as primary care providers, and other states are starting to work on legislation to do the same thing. That doesn't change our scope of practice yet, but it changes our view of how we practice. So it helps us as professionals and others recognize that physical therapists can do more than just teach exercise or do hands-on treatment, that we can help with differential diagnosis, ordering imaging, and coordinating care with the patient's healthcare providers. So we communicate frequently back to medical providers to be able to help support. The Bateman Horne Center created a clinical care guide for managing ME/CFS, long COVID, and infection-associated chronic conditions. And we tried to outline the role of different rehab providers in the guide, since a lot of people it can be confusing to know the difference between a physical therapist, occupational therapist, and speech therapist, and what each profession has to offer. I'll start with physical therapists since I'm a physical therapist myself. We are movement experts, and we can assess when someone is physiologically ready to move more or exercise. And in the case of patients with long COVID, we can also help with assessing when a patient should maybe move less or work on conserving energy and pacing their movements and activities. On the other hand, OTs are activity of daily living specialists, and they can really hone in on how to adapt the person's living circumstances and activities for conserving energy and prioritizing which activities are most important. And then speech language pathologists are communication specialists, so they can really help with cognitive function and cognitive pacing, which I don't know about you all, but I find that cognitive pacing usually is more difficult than physical pacing. For a lot of patients, they describe cognitive pacing is harder to navigate. And so I often work with my speech therapy colleagues to help how to, or refer patients to them, and also figure out how to better help this patient population. And so while each member of the rehab team has different roles, we can all screen for post-exertional malaise. We can also all support patients with activities of daily living and recommend adaptive equipment modifications or how to modify the environment. We can all teach activity pacing and energy conservation strategies, and then educate and support caregivers and family members. And one way that rehab providers can support medical providers is that we can help with assisting with the disability documentation and work and school accommodation paperwork. Some of the benefits of rehab for long COVID or patients with long COVID is usually rehab providers, we have a longer visit. So for example, my patient appointments are 1 hour, and I often see patients more often than they can get in with some of their medical specialists. So we're able to spend that extra time with the patient and dig deep into their needs and limitations and how they're responding. Another thing we can offer is that we have a specialized focused. So usually rehab providers, we're trained to be problem solvers and to try to figure out how to help patients navigate their daily activities and challenges of living with a chronic condition. And then, like I mentioned, we can help with the disability documentation. We have a lot of time with the patient, and that can help in justifying the need for disability. We can offer a view over time of how they respond to things. And then we can also help with screening for comorbid conditions. Most of my patients have a lot of other comorbid conditions, and it takes a lot of effort to dig through what might be contributing to their symptoms and their post-exertional malaise. And then we report back to their other providers. And then over time, as we regularly work with these patients, we're able to tell, like, for example, one of my patients sees, for example, this patient sees their cardiologist for managing their POTS, and I can report back how they're responding to the new medication or the new dose. Since their cardiologist can only see them every 6 months, I'm able to provide those updates to their care plan or to help their doctor make those decisions. Most referrals to physical therapy are focused on exercise, and this is what a traditional referral may look like. Often patients who developed long COVID tried to return to their normal activities, including exercise, and found that they no longer tolerated traditional exercise or activities that they used to do due to post-exertional malaise or post-exertional symptom exacerbation. And so they may struggle with taking care of their children, working, grooming, hygiene, making a meal, climbing stairs. And since many patients struggle with these ADLs, exercise and other activities may seem a little threatening since they usually have tried to do those activities and found them to be difficult to tolerate. So referrals to physical therapy should look different for patients with long COVID. If you search the term physical therapy, these are the types of images that you get, either teaching exercises or hands-on work. And so it's no wonder that when patients schedule for physical therapy for long COVID or ME/CFS, they already have a preconceived idea of what physical therapy will entail. That is exercise and hands-on treatment like those in the images here. And this can be intimidating to patients because one of the most common symptoms is fatigue or low energy and post-exertional malaise or feeling worse after exertion. So patients have these ideas of what a physical therapist will be able to provide. And so when the pandemic first hit, I had the realization that my profession, we were going to most likely not understand this condition as a whole and push people to exercise and make things a lot worse. And that's what I saw. A lot of physical therapists started pushing patients to just start doing graded exercise, and those patients would report having more difficulty with taking care of their children, taking showers, or taking care of their health, climbing stairs. And so many patients were just struggling to survive just to do their ADLs. And then the thought of going to PT for exercise was the last thing they wanted to do. And so in essence, the patient's expectations of what physical therapy was going to offer didn't match their idea of what they needed. And in some cases, some patients are so severely ill that they can't access therapy except home health or telehealth services. So during the pandemic, we were allowed a lot of times to start doing telehealth for patients. And then some of that has been gradually being taken away, which for our profession. And so that's been hard to help those patients access care. And there's not a great care model for those who are bedbound. Telehealth is somewhat good, but we really need more home health providers who know how to help, because often these patients are the ones who get the least care and are not included in research studies, and they have a hard time accessing primary care For patients who can come to the clinic, we try to adjust the environment to reduce sensory and other stressors and types of exertion that can contribute to post-exertional malaise. And let's be honest, if you look at the picture of that bed, I don't know about you, but it doesn't seem very comfortable. Hospitals and clinics, we don't do a great job of making the most comfortable, stabilizing, low stress environments for patients. That table and chair don't make me want to lay down or get comfortable, and neither do the bright fluorescent lights. So in the clinic, we try to adjust our clinic environment to reduce some of those things and make it more less stressful, and since stress can be metabolically expensive. So we'll try often to offer telehealth appointments if possible. And then when patients come to the clinic, I have a private room with a place to lie down that has minimal stimulation. I'll usually dim the lights and try to minimize the amount of paperwork that they have to do and the number of questions that I have for them. And it's not perfect, but we try our best. When patients come to therapy, they often have a preconceived idea of what physical therapy is going to be like. And so this can create a lot of stress, fear, and confusion. And they may be told by other providers that they're deconditioned and they just need to do an exercise protocol. So often patients will tell me at the end of their visit when they come in that they thought I was going to make them do some type of exercise program, or they were given an exercise program from their doctors. And some people say, I just don't know why I was sent to physical therapy for this. So I've had patients at the end of the appointment, they don't usually tell me at the beginning of the appointment, but once they have some trust in me, by the end of the appointment, they'll tell me things like, oh, I'm so glad. I was dreading that you were going to make me do exercise during this appointment and that I was going to not have enough energy for work tomorrow, or that it was going to make my symptoms worse. And so they won't usually tell me that until we've built that therapeutic relationship. And so if they're having all this fear and confusion and things before the appointment, that can increase stress and a sympathetic response that can drain the person's energy even prior to coming to the appointment. And that first interaction with the patient is key. So what I really try to do to build trust is I'll work on finding as many ways as we can to reduce stress and that sense of threat and try to build a relationship. So that first interaction is so important. So we adjust our tone to be more mellow, quiet, and calm. I'll adjust my posture not to come off very threatening, but more slouched and relaxed, leaning back. My facial expressions will be more toned down. My distance from the patient, all of those factors can communicate compassion and understanding and lower that threat and stress. I had a patient who, even at the end of the appointment, she told me, I don't usually like to work with male providers because I had a history of trauma from a provider, but I feel like I can trust you. I feel safe with you. And that's so important. She didn't share that at the beginning of the appointment. It wasn't until she felt that she could. So that first impression is so important for reducing stress and fear and confusion. When I teach other therapists about helping these patients, I try to reframe their mind. Instead of thinking, what exercise should I give this patient? Because that's often how therapists think is, oh, what am I going to give this person? And instead change it to, how can I help this person? And as this model shows, people come to physical therapy with the expectation that the therapist will be an exercise instructor, especially in most cases, patients have that idea from all the images or things they've heard. And so if they have post-exertional malaise, we try to align our expectations and goals first, so that by the end, they realize that physical therapy can be more educational and person-centered rather than exercise centered. So we'll meet in that private, quiet, dim room and set up that environment so it's less stressful. And one of the first things I do is offer for the patient to prop their legs up or lie down. And this sets the tone for the whole visit and future visits. And sometimes patients don't feel comfortable just propping themselves up or laying down. And so I really try to emphasize, like, please make yourself comfortable. I want you to be able to conserve your energy. And even saying some of those things can really help them see that we're different, that we know what we're doing and about their condition. One of the most important parts of therapy, and I always present about this, is creating a long-term relationship by listening, validating, and aligning those expectations and goals. Because the quality of the relationship can have an impact on their outcomes. And so one of the most important parts about physical therapy is the relationship with the physical therapist. In the ME/CFS Clinician Coalition, they say for ME/CFS, one of the first steps is to validate the patient experience and educate about the disease. Validating the illness for these patients is so important, that it's not laziness, it's not depression or a psychosomatic disorder, and it's not deconditioning even, that it is a serious medical condition. And then there's research showing how important it is to screen for post-exertional malaise, because when rehab providers don't, it can double the risk of health deterioration following rehab, and it can lead to ineffective, harmful healthcare. Here are some questions that I use to screen for post-exertional malaise. Sometimes people, or not questions, but these are things that some people will mention, like they never recovered after getting sick, or exercise makes them feel worse now, or they don't tolerate it anymore. Here are some of the characteristics of PIM that we use to determine if somebody has it. Symptoms appear often 12 to 48 hours after activity. There's usually a prolonged recovery. It can take days, weeks, or longer. And then it can affect multiple body systems simultaneously. And then often patients will say things like, all I did was make a meal for my husband, or all I did was go to this birthday party and I crashed for days. And that's part of that disproportionate response to exertion. And then there can be so many triggering factors that can contribute to post-exertional malaise. So here are some of the questions that I ask. Does it take more than one day to recover to your baseline after activity? And this is part of these questions come from the Workwell Foundation. How long does it take to recover after a busy day? What does a busy day look like? What does a good day versus a bad day look like? And we really try to dive into how does this person respond to activity? And part of this helps me to determine the root cause of why they're not tolerating activity or exercise. One of the questions that I find really helpful is, does exercise positively affect you? And then what exercise have you tried? Have you tried doing recumbent exercise or lying down or in water? And if so, how did that affect you? And one of the questions that's actually been really helpful, a lot of patients would tell me with dysautonomia or POTS, but who didn't have post-exertional malaise, they would say my symptoms worsen if I rest too much. So then I started asking a lot of my patients with long COVID and ME/CFS, do your symptoms worsen with resting too much? And I would often hear, no, that's the main thing that helps my symptoms. I could rest for a couple days and then I actually feel better. So that question has been really helpful in teasing out who responds better to more rest than activity. The American College of Sports Medicine guidelines recently published exercise guidelines for ME/CFS, and they note that exercise should not be presented as a curative intervention, and that it shouldn't take the place at the expense of their ADLs. So you don't want to give someone exercise that then makes it so they can't perform their ADLs because they used up all their energy for the exercise program that you gave. So that's what we emphasize to physical therapists, is not to push exercise on the patients if it's going to contribute to them having lower function. And then exercise training should not elicit PIM or contribute to PIM. And there's other research articles looking into this showing graded exercise shouldn't be recommended for those with PIM. And graded means fixed increases in activity over time. So start by walking 1 minute today, then 2 minutes tomorrow, 3 minutes the next day, and just gradually increase. That doesn't work for these patients. And I show this graphic quite often to patients with long COVID, post-exertional malaise, and it often helps them to understand better that before they contracted long COVID, they could get their heart rate up a lot higher before they would experience a crash, or they would reach this threshold that they couldn't tolerate, or that anaerobic threshold. And then after the illness, now maybe they can only go up to 100 beats a minute, and then they start going into this anaerobic metabolism. And if they stay in that too long, they're likely to crash. A lot of my patients with POTS will tell me that that threshold is around 120 to 130 that they notice. And then, but it's all the way, it's a spectrum. I have some patients who, I had one patient, his resting heart rate's 65, and then whenever he would hit 85, he would start to develop symptoms. And so he knew, I can't push past that because anytime I do, it triggers symptoms. And I wasn't planning on mentioning this, but I find this so fascinating. My patients who have service dogs, their service dogs will be able to, they can train them to sniff when they're passing that threshold and when they need to stop. And so I've had patients in the clinic who are sitting there, and I start noticing their face flushing, and then the service dog sits up and notices and gives them an alert that they're doing too much. And what was funny is one time this was happening, and the dog starts alerting the patient that they're overdoing it. And I told the patient, they pushed the dog aside, and then we had set up a heart rate alert on their watch to say, okay, this heart rate, you should probably stop and take a rest break. She pushed her service dog aside, and then the watch went off, and she turned it off and said, go ahead. And I said, no, we're not going to keep going. Let's take a rest break, because all the signals are telling us you're in that threshold where you need to take a rest break. So when I work with patients, I try to figure out how to manage all these different factors. These are recent guidelines. They came out, they were published this month from the Australian Physical Therapy Association, Journal of Physical Therapy, prioritizing pacing and planning and energy conservation are core parts of therapy for long COVID. For severe post-exertional malaise, avoid structured exercise programs and more focus on stabilization, breathing retraining, environmental adaptation, and gentle functional movements. And then allow long rest breaks between all activities, avoid pushing through the fatigue. So all of these kind of reinforce what we've been seeing with patients, that we need to work on energy conservation more than anything else, and pacing. And then this is so important, reassessing the symptoms 1 to 2 days after the session. So I'll often tell patients after their appointments, please, either you or a family member, send me a message just telling me how you did so that we can gauge, was this too much? And then I'll often reach out if I don't hear back and just call them or their family and say, hey, how did things go the day or two after the appointment? Just so that we know even the appointment wasn't too much for them. So we really have to individualize the approach. It's a compassionate, safe, and we have to be really flexible with patients with these conditions and accessible. So it takes some creativity and a lot of collaboration to treat patients with long COVID. Here are some of the interventions that we use as therapists. Number one, as I mentioned, that therapeutic relationship. So I emphasize that so much. And then also education about post-exertional malaise and energy conservation, lifestyle changes. Sometimes we'll talk about diet or other triggers that are contributing to symptoms. We'll work on screening for comorbid conditions like mast cell activation or orthostatic intolerance that may be contributing to symptoms. Or if the person has hypermobility, that can also be a factor. If they have a lot of pain, that can contribute to PIM. And then the manual therapy I'll go into in a little bit, but I found that especially helpful as well. And working on disability, care management, caregiver support. This study, I found it really interesting, and I've printed it often for patients to teach them about how to manage long COVID. This study asked over 3,900 patients with long COVID what they found to be most helpful for their symptoms. And you may not be able to see it super clearly. I'll blow up a part of it. But what you can see is that pacing was one of the most helpful approaches for long COVID and ME/CFS. And then, so I'll blow that up. On the bottom, actually, what you can see is the orange, yellow, those were all helpful. And then once you get into the blue, that made things worse. I point out to patients that no matter what intervention was tried, somebody always reported that, or there was always someone who said that it made them worse. So nothing works for everyone. We have to individualize this. And then at the bottom, graded exercise therapy made the majority of patients worse. So we really focus on pacing, which is that balancing rest with activity. And one way that I go about teaching this is when you notice signs of overdoing, like for example, you start having increased symptoms or you start having shortness of breath, those are signs that you're overdoing it. And so it would be good to stop, reduce your heart rate, maybe elevate your legs, but don't push through the symptoms. I also find that putting a cold pack on the back of the neck or on the spine is really helpful for down regulating their symptoms. Some people will use activity journals. They will mark, this one doesn't show that, but some people will mark the days that they have PIM, and then they'll mark in different colors physical exertion, mental exertion, emotional exertion, so that they can track how they're doing with their activities and whether it contributed to post-exertional malaise. And then we'll teach patients about pacing their upright activity too, because if they have orthostatic intolerance, they will have to navigate possibly wearing compression or frequently elevating the legs. A lot of my patients find that spraying cold water on their legs, if they do tolerate a shower, that spraying cold water on their legs at the end of the shower can help them not feel as fatigued after. And then we do a lot of, I've been doing a lot more over the last year, lymphatic drainage techniques, where we assess the spine and the lymphatic system and work on lymphatic drainage techniques. And that has been really helpful for patients, spending that time to get things to clear. Even yesterday, I had several patients where we worked on that and they felt much more clear after, less brain fog, clear vision. And usually when they first start this process, the first month or so, each session is a little bit rough the next morning, but it's not the same as PIM. It's more of they feel a little groggy the next day, but then they come out of it quicker than PIM. And then they start noticing that they can tolerate more activity. One of my patients who we've been doing this regularly with said, I have another spoon now. I can do more activities and tolerate more. So when new patients come into the clinic with me, I try to meet them where they're at. If I try to adjust how much I'm pushing, or not pushing, but I try to meet their sensitivity level. I may offer a telehealth appointment if they aren't able to come in, But if they want to focus on exercise, then we can talk about that. But I don't usually ever start a session with exercise. Um, we'll treat it more like a spa day. We'll do activities to reduce the symptoms, and I'll ask what they usually feel better with. Like if it's a cold pack or a warm pack, I'll have them lay down. I may put pneumatic compression boots on their legs. And then we just ask, what do you want to focus on today? How many spoons do you have left? Or how much energy? We'll also ask, what else do you need to do after the appointment or over the next couple days? Because I don't want to, if you do end up having some post-exertional malaise, I don't want to affect any of your other activities. And so we'll try all these things to dim the lights, put a cold pack on the back of the neck, maybe the abdomen, and then work on lymphatic drainage. And that has been really beneficial for this patient population. So when you refer to a physical therapist for long COVID, we wrote out an example of what you could put. I'll just mention that some of the key points are: let us know that the patient has post-exertional malaise and not to prescribe graded exercise, especially if a physical therapist isn't familiar with treating a patient with long COVID or ME/CFS. We want to really clarify, don't push them, don't push a bunch of exertion-based testing, and offer telehealth option if you can. And then when you also make the referral to rehab providers, it's helpful if you can include any comorbid conditions like orthostatic intolerance or Ehlers-Danlos or any other things that can help us to navigate helping that patient. I hear this a lot. Patients and providers will say, well, how do I find a local physical therapist or rehab provider who understands this? And what I've found is that the patient support groups usually filter out the providers. So usually patient support groups will say, hey, this provider understood and they didn't push me to do a bunch of exercise. They understood long COVID. So those are a lot of time where you can find who patients are recommending. And then also based on patient feedback, if somebody like a physical therapist or occupational therapist has on their website, I treat ME/CFS, I treat long COVID, it's better to meet them and vet them versus just assume that because they are marketing that they do that they'll know what to do or that they'll do it appropriately. Here's some resources of what that we've made at Bateman Horn Center to educate rehab providers. So these are available for PTs, OTs, speech therapists that can help them in learning how to better help these patients. And so I hope this gives you a snapshot of what therapists can offer patients with long COVID. At the beginning of the pandemic, there weren't very many resources for therapists to know how to help. Now there are a lot of other resources like long COVID physio, and there's so many resources out there now that if the therapist wants to find them and learn about it, there's plenty out there. So thank you so much for this opportunity. Here's some of my contact information, and then I have reference as well.
All right, perfect. And it looks like we've got some questions from Dr. Chow.
Yeah, I think thank you for such a nice talk in terms of having our patients kind of pace themselves. So I have a couple of patients who basically are not able to even get out of bed. Or how do you engage them? They seem so resistant to doing any type of activity, and I feel for them. I mean, they've probably been deconditioned for at least a couple months. How do you engage patients to take the first steps and start, and how do you get them and encourage them to start exercise, not graded exercise, but just regular exercise, and how would that look like?
Yeah, no, that's a great question because often while ME/CFS or long COVID isn't deconditioning, deconditioning can worsen some of the symptoms and be part of this. With patients who are bedbound, often I'm looking to figure out, is there some type of comorbid condition orthostatic intolerance that's keeping them from getting up, and what kind of things can we do to improve some of those symptoms. If I was treating, for example, some of my bed-bound patients, we start with the gentle lymphatic work and getting things moving passively for them. So instead of having them actively try to start moving, we'll passively start moving the body if we can, and working on getting rid of some of the buildup lymph and getting improved circulation. So some patients will use pneumatic compression boots to kind of start pushing fluid out of the legs and up. But yeah, it's really challenging with the more severe patients because they can be extremely sensitive. So it's really often figuring out what their triggers are and things, and it's individualized to each one.
Yeah, and so that there's some people who talk about CHOP, and so I know some of my patients, they said they look at it and they go, yeah, that's great, but I can't do it.
Yeah, yeah, the
And
CHOP
it's very,
protocol is interesting because they in that research we did a paper where we did a meta-analysis of all the papers about exercise and POTS. And what I was on the team that looked at risk of bias in these papers. And what was interesting is like most of the research papers for exercise for POTS excluded EDS and mast cell activation. And then they had high dropout rates and low tolerance for the program. Um, and so, yeah, a lot of patients will be given a CHOP protocol or and things. And so for those patients, it's really, we work more on gentle movement, starting to get them doing just range of motion or even working on breathing, some of the more basic things before we would approach aerobic exercise, maybe even just isometric exercises to strengthen or to not strengthen, but to get activation of certain areas. But that's usually how we'll have to start with those patients is more lymphatic passive movements or very gentle movement to not trigger it. And then I also see that you have a question about wearable devices for patients. So I can touch on that if you don't mind. Uh, there's a lot of, so the wearable devices, I use them a lot initially. So for new patients who are navigating this and don't really know how to pace and haven't figured out what signals, sometimes wearing a heart rate device like an Apple Watch or I don't I haven't loved Fitbit, but Apple Watch, Garmin, Visible also has heart rate alerts. And what we'll do is we'll try to figure out at what exertion level they start to get symptoms and try to estimate, okay, you tend to start getting into that passing your threshold at this heart rate, and let's try to figure out a time when you're overexerting, we can give you an alert. It doesn't work for patients who are super hypervigilant, or that can actually trigger a sympathetic response when their heart rate alert goes off. So that's also kind of tricky. I, I don't know if you've heard of the Lumia device. That one is really helpful as well for patients who can afford it. Lumia Health has a device that goes in the ear and looks at blood flow to the brain. Um, they use a branch of the external carotid that correlates with blood flow to the brain. In the clinic, it's really cool to have that on patients and see their blood flow drop when they sit up or when they stand. So that's been helpful for some patients to see that what the activity they're doing, they start to have a drop in flow.
Sure, thank you. We could move on with Cynthia and Lilani's questions.
Okay. Yeah. So the question is, as a psychotherapist who hears regular debriefs about from our patients referred to PT who have had less than positive experiences, many express that they do not feel equipped with the language or ability to advocate for what their limits are to their PT. Are there any approaches you have seen be effective in improving patient communication with their providers?
I asked that question because sometimes our patients are of a population, they have limited options. So they kind of have to accept whatever PT referral will accept to them as a patient or a client. And so they feel stuck, like they know they need the treatment, but they go, they don't feel, they feel a power dynamic differential, or this person doesn't really believe my symptoms. And they feel pushed beyond what they're comfortable doing and then sort of just don't go back. They'll just attrition is a very common thing that I
Yes.
hear about, and then trying to get them like to go back and how to talk with their provider about what the limits are. Any magic words or
No, this is a great point. There's a Facebook group of physical therapists who have ME/CFS or long COVID or both. And they have been trying to create resources for going to your physical therapist with a handout and other things that say, here's what I have, don't push me. We find that usually have in the moment, it's too hard to communicate those things with the therapist. If you go in and try to communicate, I have post-exertional malaise, I have ME/CFS, or long COVID, they're not going to know how to take that. And so we usually recommend having a handout, a very simple one-page handout that says, I have the post-exertional malaise, or I have a neurologic condition that makes it so that when I exercise or exert myself, it worsens my symptoms for days. Um, can you help me? And then have a very specific, can you help me with my shoulder pain?
yeah,
But, or if that's what they're seeking, if they're seeking long care for like learning how to pace and all that, then that's a little bit more tricky than if they're seeking something like, I just need you to help me with my knee pain.
right.
Um, so, but yeah, that's why we're doing lots of training around the country for patient or for PTs to make them aware. Um,
And I think even for referring providers, right? Like that makes me
yes,
think like maybe I need to go back and put in a smart phrase that could be printed in the patient instructions with their referral order that says, this is what we're recommending. This is why this patient has these limits because of XYZ.
yes,
Maybe that would
yeah,
sort of empower the patients.
exactly. A one-page handout. I made some videos that are like 2 minutes long, 3 minutes long, that I will send patients that they then show their family members or their doctor that explain it simply, and that seems to help because then people believe it more. When a
Yes,
patient says, I have this, people are skeptical, but when it's from a different source, it helps them. So
exactly what
usually a
I
one-page document saying, this is what I have and I can't tolerate exercise. Some physical therapists will go, well, then how am I going to help? Even some colleagues I've had say, what am I supposed to do if I can't give them this? And but most therapists have learned some principles of energy conservation and pacing. It's just, it's it's hard to find providers who really understand like first steps, how to help. I find that like the lymph, some of the lymphatic drained or lymphatic drainage therapists and manual therapists have a little bit better understanding, like craniosacral. Some of these more gentle therapies can be somewhat helpful.
That's an excellent point. Can I ask a follow-up question
Oh
to that,
yeah.
or am I hogging too much time? So I work in a family medicine residency training program, and we also have a lot of osteopathic physicians who practice OMT or are being trained to practice OMT. What is the overlap between, because you just mentioned things like lymphatic drainage and, certain kinds of releases and things like that. And
There's a
so,
lot of overlap with the
okay,
like with osteopathic and PT, chiropractic, and then some of the massage therapists, if they have, not all the training's going to help for this patient population, but there is specific training coming out for helping to drain the lymphatic system, as that seems to be a piece of the puzzle for some of these patients. And as I've been doing it over the last year with patients, we are writing some case reports about patients
Mm,
improving. It's been really interesting to see that it's helping them slowly improve their function.
I believe it. That's fantastic. Thank you.
No problem.
Okay, and correct me if I'm wrong, but I think Cynthia really liked what you said about having when she said well said, it was when you were talking about making the environments a more comfortable and inviting environment. So,
You can see my office. I have the low lights. I
Yeah.
have the fairy lights above that I have off right now, but I have a lot of sensory oversaturation as someone who's neurospicy at baseline. So I totally resonated with what you were saying. I love it.
As
Yeah,
opposed
most
to our
healthcare environments.
sanitary unit
Go ahead.
here.
What was that?
And the bed that's very uncomfortable.
It's hard. Hospital settings, just we try to make it more comfortable. Yeah, it's tough to try to see, okay, how could I adjust this to make it a little bit more comfortable for the patient, less threatening.
Less
The
frightening.
dim lights are helpful, and then usually telling the patient right away, like, you can lay down. I want you to feel comfortable. Putting a pillow underneath the legs, like a wedge or things, and just helping them feel like, just get comfortable here. I'm just here to talk with you.
okay, perfect. And then Leilani said, thank you for this presentation. You come across as a very empathetic and kind provider. Wish all my friends with long COVID were able to see someone like you.
Thank you, Leilani.
Yeah, that's some great information. Does anybody else have any questions? I don't see anything else coming up. And I will just remind everybody that the slides from this presentation are already on the iEcho website, and the recording will be up in a week if you want to refer back to it or have some of your colleagues review it. So thank you, Dr. Powers, for joining us today. We really appreciate it. And everybody remember to complete your evaluation forms. And then if you're interested, our next session is on May the 12th, and the topic that day will be pediatric long COVID, what every clinician needs to know. So thank you for joining us. Have a great day.